Senator Coons.
Thank you, Chairman Grassley, Ranking Member Durbin, for convening this, and thank you to the panel for your important work. Let me ask a few questions, if I might. In my small state of Delaware from 2018 to 2020, Delawareans footed the bill for over $24 million in unnecessary prescription drug payments, largely due to the practices that have been the focus of this hearing. And as a state, we have now enacted a series of PBM reform laws, notably all passed unanimously through our state legislature. I don't think that happens very often in any state. So I'm glad that PBM reform has some level of bipartisan support in Congress, including bills led by Chairman Grassley and other members of this committee. In fact, a ban on so-called spread pricing was one of the only provisions that I was glad to see in the House Republicans' reconciliation bill. Of course, I would have chosen to use the $1 billion in savings to fund community health centers and combat the opioid epidemic, not to give bigger tax cuts. But I'm glad for the opportunity to discuss what reforms could bring transparency, lower drug prices, and improve patient access. If I could, Dr. Kirschner, thank you for your work on pancreatic cancer disease that's impacted my family specifically. I've received substantial outreach from Delawareans about the need for PBM reform, from clergy to breast cancer survivors. How do PBM practices make it harder for patients struggling with cancer treatment to access life-saving medications?
There's a couple different ways, and the patients don't know that a PBM's even involved.
Right.
But where the rubber hits the road for them is like the disconnect between my prescription pad and them receiving the drug. Like some black box happens sometimes when we can't fill it at our specialty pharmacies, and that might be different within different specialties. So these are for highly complex chemotherapy drugs. And so patients, when we can't use our own pharmacy, really negatively are impacted.
I've seen that directly, personally, with 3 family members who've died of cancer. But thank you for your work and for raising that issue today. If I could, to Mr. Scott and Dr. McDonough, I've seen reports as high as 80% of rural and independent pharmacies receive reimbursement below the cost of procuring and dispensing some drugs. The owner of an independent pharmacy in southern Delaware told me he can no longer even afford to stock certain expensive treatments for HIV, GLP-1s. His reimbursements after PBM fees are unpredictable, and he can't afford to lose money every time he dispenses one of these. Mr. Scott, why isn't there greater transparency into the reimbursement process? And Dr. McDonough, how could greater transparency help level the playing field, particularly for independent pharmacies and rural pharmacies?
I'll go first and briefly to say, understand the mechanics of how this works, because there is transparency when the pharmacy is choosing to contract to be part of a PBM's recommended network. Right. And more than 85% of those independent pharmacies are actually empowering a wholesaler through their PSAO, Pharmacy Services Administrative Organization, to negotiate on their behalf. You have 3 big wholesalers controlling 90% of the market. They're selling the drugs to the pharmacy, and they're negotiating these contracts on their behalf. And that is the starting point for determining how the reimbursement is going to flow to a pharmacy in a network.
I think transparency is key. You know, when you think about the physician writing the prescription and then the end user being the patient and normally filled at a pharmacy, there's a lot of stuff that happens in between. Right. And where things are getting siphoned off and everything else and fees. And I think, one, spread pricing we know is real. We, as an independent pharmacy, we had a local employer who approached us and asked us if we would be willing to do direct contracting with them. I was lucky that this CEO had experience in the insurance agency area, and he said that, you know, I want to see what if you give us a direct price, what that would do. That's been 5 years ago. They stay with us. They've saved a heck of a lot of money. Patients are happy because they get to go to a pharmacy that's going to provide services for them, and we actually made some money where we could stay open. So I do think transparency all along the line to find out what's going on. But I also think when we talk about rebates, that's so opaque. What do we have to do to really understand about rebates, and do we need rebates? I mean, that's a broad and a radical thing of thinking about, but let's just start from the very scratch and saying, you know, can we do something where we know our actual cost I couldn't tell you what my actual cost is because of rebates. So I do think we have to have a lot more transparency.
Ms. Faust, Dr. Faust, to follow up on the point Dr. McDonough just made, should all PBMs be required to operate with the same level of transparency as yours when it comes to selecting drugs and obtaining rebates? And what other practices could PBMs learn from your company?
Yeah, we believe wholeheartedly in transparency and passing through rebates, especially as it relates to passing that savings through to the client. All PBMs should have transparency across the entire drug supply chain. And so that would be a great first step around rebates.
Thank you to all the witnesses today. Thank you.